Hello and welcome to the Feeling Good podcast. I am your host, Fabrice Nye, and joining me here in the Murrieta studios is Dr. David Burns. Hi, David.
Hi, Fabrice.
Dr. David Burns has been a pioneer in the development of cognitive therapy, and he is the creator of the new team therapy. He is the author of Feeling Good, which has sold over 5 million copies in the United States and has been translated into over 20 languages. He is an emeritus adjunct clinical professor of psychiatry at the Stanford University School of Medicine. Welcome to episode 102 of the Feeling Good podcast. We're reconvening here, David and I, after several weeks of not seeing each other. Lots of things have happened, especially on the workshop front. David, you did an intensive in Whistler and then one in South San Francisco. Want to tell us how those went?
They were really tremendous experiences. The ratings at both locations were pretty much the highest workshop ratings I've had in 25 or 30 years.
Why is that?
Well, I did two things. I've been kind of practicing what I preach to a certain extent. And when we've done the interpersonal model, we've talked about that you get back what you put out. We create our own interpersonal reality. Right. And I've been asking myself, what are the things that I do that are really helpful to people? And then what are the things I do in teaching that are kind of turnoffs to people?
Yeah.
And so what I did at both locations, and although I'm still not perfect at it, I can still slip up, but I was way better at treating every single person with warmth and respect. So sometimes people will ask questions that I find a little irritating or annoying, and then I make the mistake of kind of responding in a sharp way or putting them down or in a subtle way, and that hurts people's feelings, and I always end up regretting it. So I was just a lot more careful than usual, as I say, not perfect, but really trying to make every person feel terrific about their question and about their contribution there. So it would be a spirit uplifting.
And also to do that in a genuine way.
Yeah.
Not fake,
Exactly. Of course, I get positive and negative feedback, written and ratings every day of a workshop, and then I read the worst ratings and the best the next morning out loud, and people really like that. And on the third day of the San Francisco one, or the night two, I got this slightly negative feedback, although ratings were just sky high all throughout. But someone said, you're always saying everyone's question is so important and the best one. You're always responding in that way. Is that genuine, type of thing? And then I read it the next morning, and I said, oh, that's such a wonderful comment. And everybody laughed and kind of got a kick out of that. Also at both locations, another thing that was great were the live demonstrations, and we had tremendous ultra high definition video photography of both of them. And I'm waiting to find out if we can use them for
that would be wonderful.
Teaching.
Get people a taste of what they would get if they went to an intensive.
Yeah.
Anybody who has not been to one of those can't quite get how many skills you can get just from spending a few days just working on these skills one at a time.
Yeah. So they were great. The one in Whistler is a woman who had been multiple, just pretty horrible sexual assaults, and she'd been down for a good 10 years about that. Mm-hmm. And it was just a total blow away. She was just in a state of euphoria by the end of the workshop, by the end of the actual demonstration on the evening of day one. But it's sensitive because some of the assaults occurred within her family system.
Ah, yes.
So I have to wait and find out. But it was one of the most mind-blowing sessions ever, although so many of them seem like that. And then at the one in South San Francisco, my co-therapist was Dr. Jill Levitt. Up in Whistler was Mike Christiansen, was my co-therapist. And they both have online training. For any of you who are interested, go to the Feeling Good Institute website. They're both about to start 12
Yeah, I might want to add that Jill was keen on us letting people know that what we're talking about, they can be formally trained in all of these methods, all of those techniques, if they go to the Feeling Good Institute. It's feelinggoodinstitute.com.
Yeah.
And there's a menu of upcoming trainings that they can join, and consultation groups.
Yeah, the quality is just sky high, because these are some of the best therapists and teachers around. But anyway, Jill was my co-therapist. Whenever I worked with her, it's blow away. And we had a fellow who came in from the East Coast and asked to be the live demonstration volunteer. And he's had like OCD since childhood, pretty severe. And he was waking up in the middle of the night. He lives with his mom, and she's getting into her late 80s, and he's afraid of losing her and ending up alone. And he's having just the most horrific panic attacks in the middle of the night, and always kind of checking things, and just a blizzard of anxiety. Yeah. And he was just wonderful to work with. Yeah. And it was just another fantastic, live demo by the first day of the workshop. And then when people see that, they think, like seeing is believing. This is for real. You can really see these dramatic changes in a remarkably short period of time. And the people get not only symptom free, but they kind of go into a state of euphoria. It's a fantastic thing to behold. But the other thing I did that really helped was to think of the people in the workshop as children, the participants, and to teach on a very simple level, little bite-sized chunks, and first describe it and then demonstrate it on stage, and then let them practice it at the tables and things.
You're not talking about, seeing them as children in terms of maturity level.
Yeah.
Yeah, really? Well, they're going to love that.
We're all children, we want to play, we want to have fun. Yeah. And then I gave them fun things to do too. And so it was just a nice, warm spirit, and people felt like they were learning and getting somewhere. And then there were so many people from my Tuesday group at the one here in San Francisco that we had as many as 14 helpers at any one time helping with the small group exercises. And so it was just a fabulous event. Now we've got 2 more workshops coming up. October 4 and 5, it's rapid recovery from trauma. I'm going to be doing that in Pasadena, California, October 4 and 5, a 2-day workshop.
2018.
And there will be a live demo again on the evening of day 1. Mm-hmm. And then I'm repeating the same workshop in Woodland Hills, California on November 1 and 2 of 2018. And so if you're interested in attending, and the one in Woodland Hills on November 1 and 2, I guess they have live streaming so you can attend from home.
Yeah, it's a webcast,
Yeah. And to learn more about those, go to www.iahb. Is IAHB or IABH?
IAHB.
IA, Institute for the Advancements of Human Behavior.
Yeah, I think that's what it is.
.org, IAHB.org. You get all the details and register.
Yeah. And you're going to do something in December also, I think I saw on your website.
Yeah, I'm going to do a bunch of things, as it turns out, but I'm going to give a keynote address at this brief therapy
the brief
conference.
Therapy conference. And it's going to be around here in Burlingame.
Yeah, it's usually down in Anaheim, California, sometimes on the East Coast, but it's the Ericksonian Institute in Phoenix who sponsors it. Jeffrey Zeig is the head of that.
Yeah, I might be interested in going to that, And
and I'm going to do that, and then I'm going to do a live demo with Jill, a 2-hour live demo, which should be fantastic, hopefully.
It's going to be standing room only.
Hopefully, yeah. Well, yeah,
I mean, you and Jill have such a chemistry. It's just amazing.
Yeah. So anyway, that's coming up too, and those Ericksonian conferences are just always the best. They're beautifully organized. They have top speakers, huge crowds, user-friendly environment.
Great. Well, lots to look forward to. So now let's talk about today's topic. So some of your colleagues have asked about what do you do with somebody who shows up in your practice? Maybe it's your initial evaluation, and they're saying, doctor, I'm depressed. I'm thinking about killing myself. And you have somebody on your hands who is, thinking seriously about self-harm.
Yeah.
What do you do? And especially what do you do in the team model that's different from what we're used to?
Yeah, well, that's a great question. And Moore Katz was the one who actually asked it. He's the head of the Feeling Good Institute in Mountain View, and he wanted all of his staff to be aware of this approach that I've developed to dealing with suicidal patients. But suicide is very common. The urges for suicidal urges and suicidal fantasies in people who are significantly depressed, almost all of them. So if you're treating patients who are depressed, you definitely want to learn how to evaluate suicidal urges and how to prevent suicide attempts and how to predict who's going to be suicidal. Now, some of the things I'll describe are things that most good therapists would know how to do, and then you'll be thinking, oh, I've heard all of this, a radical for therapists to think about. But the first easy diagnostic system, which diagnoses 50 or 60 of the most common DSM-5, ICD-10 diagnoses. The patients can take it on their own, so you don't waste therapy time taking this test, and then they hand it to you in 5 minutes or so in a session. You can assign the 50 most common diagnoses as not present, possibly present, or definitely present. But among other things, I have quite a few questions on suicidal urges and also homicidal urges. We'll just focus on the suicidal part.
Yeah.
And so if a patient indicates that they're having some elevated suicidal fantasies or urges, I immediately do a suicide evaluation, and I have a 3-page structured suicide evaluation showing you the questions to ask. It's in my psychotherapy ebook. Also, anyone with a toolkit, there's a chapter in the test as well as a little article on how to prevent suicide attempts and what to do about the suicidal patient. But the interview just goes over the things the questions that an expert would ask. What are the important things? And you write down the patient's answers while you're asking these questions. And so, one thing is to ask about hopelessness. Beck was talked about, and some research has shown that hopelessness is highly correlated with suicidal urges. Mm-hmm. The idea being that if you're in pain, like I have this back abscess right now that I had drained at Kaiser a few days ago.
And that makes you feel hopeless.
No, because they say it's getting better, the pain's getting better, and, it's kind of painful. I have to have the wounds changed every couple of days. But I can see it's getting better, so I feel good about it. But when you feel hopeless, you feel like things won't get better. You're going to be depressed forever. And the hopelessness in depressed patients is always based on cognitive distortions. It's never valid.
Yeah.
But the patient strongly believes I'm hopeless. And so if the patient has strong feelings of hopelessness, then that's the thing that often triggers suicidal urges.
Yeah, in fact, your first question in the risk factors in the suicide assessment is how hopeless does the patient feel?
Yeah, absolutely. And then secondly, you ask them how strong is your desire to live? Are there times when you have a strong desire to kill yourself, to take your life, and tell me about those feelings?
That's question number 3.
Yeah. You have the test?
I have it in front of me right here.
Oh, fabulous. Yeah, I haven't looked at it for a long time. From a suicide attempt.
The protective factors, yeah.
Yeah, and some people will say, well, beliefs. And in my experience, if there's a strong deterrent, you're usually, what would trigger you to make a suicide attempt? Suppose your boyfriend left you or your girlfriend left you, or suppose you lost your job. What are the things that would put you on the edge of making a suicide attempt? Another question is, have you made suicide attempts in the past? And you can ask about those.
That's a strong predictor, yeah.
Yeah. And some people think, well, if they had a failed suicide attempt in the past, then they're just doing it to get attention and they're not really dangerous. Kind of the suicide attempt is a call for help. But
well, any attempt is dangerous. You can you can miss yourself in this. In the sense that
and it's misleading to say it's a call for help. Well, often they're like practice attempts, and each time they learn more about what it's going to take to kill themselves. Another question is what method would you use?
Yeah.
Would you jump? Would you hang yourself? Would you shoot yourself? Would you take pills? Would you poison yourself? And then what specific preparation have you made? Oh, you're going to use a gun. Do you own a gun? Have you purchased a gun? Do you have the bullets? Have you practiced shooting the gun?
Yeah.
And the more specific their plan is, and the more prepared they are, the more dangerous they are. Another question to ask is, do you sometimes get drunk or use drugs and get stoned, and then do you become more suicidal and more impulsive when you're high? Another question is, do you have a support network? If you began to feel suicidal, would you call me? I used to tell my patients I don't like to take emergency calls, but the one time I'd rather hear from you at 1 a.m. than hear from the coroner at 3 a.m. Who would support you and who you would trust to reach out to. Ask, does this person appear to be reliable? Do you think they're giving you the straight answer? Coming to therapy voluntarily, or is someone pushing them to come to therapy?
I don't know how you think about it, but you're essentially listing most of the questions you have on your suicide assessment. You might want to put that in the show notes. Yeah. I know that this is part of your toolkit, but it's up to you.
We could put that in. That's not a problem.
Yeah.
And there could be some other questions, but mainly you want to ask those questions and document their answers so you can put that in your chart. Another thing before I come to crunch time is that I require all patients to take the brief mood survey, as you know, before and after every session. And there are 2 suicide items that they take before each session. And then there's 2 suicide questions that they take after each session in the waiting room. So you also have that information at every single therapy session. So therapists who follow this approach will be well armed with good information.
Can I say something about the brief mood survey?
Jump in.
Especially in my patients have suicidal ideation. Maximum, or if I may say, all of them, they don't have an intent or a plan. So they're not highly suicidal. And so I might get lulled into not even worrying about it.
Exactly.
But if I didn't have that little item, that most of them, they'll check no. That's fine.
Yeah.
But now and then there's a 1 or even a 2. It's like, and then you get to talk about it.
Exactly.
And if I had not had the mood survey, this would have gone unnoticed.
Absolutely. The brief mood survey can save patients' lives. And we mentioned on previous podcasts when I did research on therapist accuracy. How accurate are you knowing how depressed your patient is, how suicidal, how angry, that type of thing. The accuracy of therapists in clinical practice as well as experts at places like Stanford is 0. They absolutely couldn't figure out how suicidal patients were even after a 2 or 3 or 4 hour interview with the patient.
Yeah.
They couldn't get it right. And so if you have the brief mood survey, automatically you'll be checking for suicidal urges twice every session. Now here's the part of it that will be controversial and perhaps a bit unique. Now here's what you might call the crunch time issue and the part that will be a bit controversial. Some patients, particularly those with borderline personality disorder.
Oh, pause. I know why it stopped. It stopped because I hadn't pressed the record button.
Oh, so we lost everything?
Well, no, we didn't.
We got
it
here. Okay. All right, good.
Gosh, it's a good thing we have this backup. Let me press the record button.
Well, is there any point in recording the second half?
No, but...
Okay.
All right.
Now here's the crunch time. Therapists who work with a severe population, like when I had my clinic in Philadelphia, people came from all over the world because they'd read Feeling Good and hadn't been able to find help locally. And so they were very severe, and 28% of our patients had borderline personality disorder at intake, and they can sometimes be manipulative, and that word might sound insulting, so I apologize if it's not politically correct, but the type of thing I'm referring to, we had a young woman came in for an intensive, and she was working with one of my therapists. She came from the West Coast to Philadelphia, and she had severe depression and borderline personality disorder, and sometimes they like to use suicide attempts, suicidal threats as a way of creating distress for the therapist, and she called her therapist, who we'll call him Roger, it wasn't his name, but just to protect everything, and said, "Oh, Dr. Roger, I just wanted to call you to thank you for all the help you've been giving me in the last few days in this intensive therapy. I want you to know that I just moved to a new apartment, so you won't be able to locate me. But I'm lying on the dining room table, and I just put a needle in my artery in my arm, and I'm watching the blood spurt onto the wall. But I'm calling because so you won't worry, because I usually know how to pull out the needle at just the last minute." And then she hung up on him. And
holy moly!
Yeah, it is pretty distressing, and we had actually quite a few stories like that because we had a severe patient population, and so the method I developed is to if I'm not confident in the patient at the initial evaluation, and not confident that they've really convinced me that they will not make a suicide attempt, I would say to them, and this is part of agenda setting, to say, if you want to work with me, and I hope you will, because I've got some fabulous tools, and what a joy it would be to show you how to recover from depression and get back to joy and self-esteem. And I believe if we work together, we can bring about that result. But there would be a price you'd have to pay. Several prices, really, but one of them is you would have to guarantee to me that you will never make a suicide attempt for the rest of your life, no matter what. And if you're willing to make that commitment, I'm willing to work with you. But if you're not willing to make that commitment, I can't ethically accept you as my patient.
So I have a couple questions there. You're kind of putting the patient in front of an ultimatum.
Right, gentle ultimatum.
Well, I'm not sure if that's that gentle.
Okay, a firm ultimatum.
Yes, kind of firm. And the other thing is, a lot of therapists have a contract, a no suicide contract. How is that different?
I think the research has shown that these suicide contracts on inpatient units or with outpatients, you ask the patient to promise they'll never make a suicide attempt while they're in therapy with you. And the difficulty with that is the moment they decide to make a suicide attempt, they're thinking, I'm not in therapy anymore, so I'm just going to go ahead and kill myself, because then I'll be, essentially dropped out of therapy.
Uh-huh.
And
so you're asking the patient to never for the rest of their life commit suicide.
Yeah, and you'd have to convince me of that here today, and I'm going to be a fairly skeptical, in cross-examining you. Now, there's two kind of reactions that I would get. Occasionally, a real angry patient would say, well, that's unfair. I have the right to commit suicide anytime I want. That's my right as a human being. I say, God bless you. I agree with you, and I do respect that right. But by the same token, if you want to set it up like that, I can't ethically be your patient, and there's your therapist, and there's three reasons for that.
Mm-hmm.
The first reason is if I take you on under those conditions, every weekend, I won't know if you'll be alive on Monday. I'll be worrying about you. And you'll be making my life miserable. I'll be giving you the power to make my life miserable. So, but I think we're one. We're not two people, we're one. We're a team, and we're going to go up and down together. And so if I allow you to make my life miserable, there's no way I can show you how to make your life happy and fulfilled. The second reason is that if you keep that suicide option open, as I say, I respect your right to do that if that's the way you want to set it up, but that will make all of my techniques ineffective. So there would be no point in us working together under those conditions.
And why would they be ineffective?
Because the person isn't really committed to the treatment. They're kind of testing you and manipulating the therapist. Their heart isn't set on recovery, on doing homework, on working really hard to. I don't know the answer to the question, to tell you the truth. I just know that it's a fact. And then finally, if I accept you under those conditions, the likelihood is high that you are going to attempt suicide and kill yourself through suicide. And so I'll be playing Russian roulette with your life.
So why would that be a high likelihood?
Well, because the patients who make suicide attempts and who won't make a commitment not to kill themselves, most of them do go ahead and kill themselves. Mm-hmm. They do end up with completed suicide, death by suicide.
What did they say to you? Well, I'll commit. I'll commit until we're no longer in therapy.
Yeah, that won't work for me, but there's many therapists, and I'd hate to lose you because I was hoping to work with you, but there are many therapists in the community who will take you under those conditions. And if you go to one of them and you're unhappy and want to come back, my door is always open to you.
But, while we're working together, I'll put all my heart into doing your methods and everything.
That's great, but I couldn't stand the stress, to tell you the truth, of working with you under those conditions. I'd be constantly worrying with you, and I can't accept you as a patient with integrity. But if you change your mind at any point and want to come back, it would be a joy to work with you. Mm-hmm.
So, in other words, you're pretty inflexible about this.
Yeah, it's an agenda-setting issue.
Yeah.
And it was hard for me to come to it at first. And some of my students have initially said, oh, that's too tough, and you want to help everybody, you want to be so kind to everybody. But this is the only technique I found that's really, really effective. And I think of it as kind of defensive driving. In high school, we had this great defensive driving class, and the idea was if you're ever in an accident, it's your fault, no matter what. Even if the other person is legally to blame, runs a red light and smashes into you, the idea is you should be driving defensively, so you're thinking about these things and avoiding these things. And it's the same thing to my way of thinking in clinical practice. Mm-hmm. It's defensive clinical practice for protecting yourself. A suicide attempt by a patient or a completed suicide, death by suicide, is a horrific thing. It's devastating for everyone. It's a tragic loss of the patient's life. It's devastating to the family, of course, because it's often hard for them to get over it. Some of them never get over the guilt, the shame, the anger, the remorse, the sadness, what I should have known, all of that. Right. But it's also devastating to the therapist, the shame that the therapist feels, the anger, the frustration, the anxiety. A quarter of the suicides end up in with lawsuits that can stretch on for years. And it's the dark side of our profession. Our profession is filled with joy, and I see people like intensive just being transformed before my very eyes all the time now. It's like magic. It's like miracles. But there's a downside, and this is the downside. And that's the approach that I've developed for working with suicidal patients. And it's defensive to protect me. I'm sorry, I hit my microphone. But because we're one, the thing that protects me and is ethical for me also protects the patient.
So to summarize, when you have a suicidal patient who comes to you, number one, you do the assessment, using your suicide assessment. And then you go into agenda setting and you get that commitment from them.
Yeah.
Using the, gentle ultimatum and sitting with open hands.
Yeah.
And wait for them to commit.
Yeah.
And either they do and you're willing to work with them, or they don't and you refer them out.
Yeah.
Okay.
Absolutely.
All right. Well, I hope this is helpful to clinicians and non-clinicians alike out there. Thank you, David.
Thank you. It's kind of a heavy topic today, but
I know.
Hopefully it'll be helpful to some people and more. Thank you for the question, and I hope this will be helpful to the clinicians at the Feeling Good Institute, because it's a tough pill to swallow. But if you don't deal with this, the dealing with the suicide of a patient is pretty devastating.
Yeah, I've been through that myself.
Yeah, well, maybe we'll have another podcast on that, how to deal with the clinicians' feelings.
Yeah. All right, well, thank you so much. This has been another episode of the Feeling Good podcast. For more information, visit Dr. Burns' website at feelinggood.com, where you will find the show notes for this podcast under the blog page, and where you can leave your comments and questions. The website has an abundance of resources for therapists as well as non-therapists, including books, workshops, a list of online training groups around the world, and much more. Theme music is Gypsy Jazz in Paris, 1935, composed and performed by Brett Van Donsel. I am your host, Fabrice Nye, and I invite you to join us next time for another episode of the Feeling Good podcast.